My name is Karen Brown. I'm a primary care doctor at Northeast Medical Group in North Haven, New Haven, Connecticut. And my colleague Ann Chang and I lead this Smilow Shares with Primary Care series. And this is the last session of this academic year. We welcome you. Thank you for the time that it takes to attend. I hope that we will have a terrific session. It looks like it will be. The topic is lumps and bumps. It sounds kind of silly, but you know, in primary care, one of the things that happens is people come in and they show us things. And sometimes they look pretty funny to us, and sometimes they just look like a normal part of the body to us. But our job is to really help to triage what needs further attention and not. And so that was the impetus to actually name the talk Lumps and Bumps rather than something kind of a little more intrinsically Latinly medical. And so if you move to the next slide. I'll just remind you that this is a monthly series, although we will be taking a break over the summer months with an intended audience of primary care clinicians. And our faculty always has a primary care clinician with our Smilow specialist. And here at Yale, Smilow is our Smilow Cancer Center that has a multidisciplinary group of clinicians affiliated with it, and tonight is no exception. It's not just an oncologist. We often have a radiologist, pathologist, geneticist, and others join us. It is always the first Tuesday of each month, and really the main thing is we realized that a typical lecture on a specific form of cancer was kind of helpful to those of us in primary care. But what we really also needed was an approach to evaluating new problems and getting people to the care they need when they did turn out to have cancer. And it's not always as straightforward as you would think. And there's also, we won't be talking about it today, but in many of our talks, we talk about the other end of the handoff back from oncology back to primary care. And so it is those interfaces of care where we like to focus in this series. We're always case-based, and tonight is no exception. We'll review 3 cases. And so we have 3 cases. We'll have discussion. Please feel free to submit your questions in the questions section, and we will get to them either between cases or at the end, depending on the flow. And that'll be it. I'm going to kick us off with some introductions. So I'll introduce Dr. Beth Allard, who is, a wonderful colleague, a primary care physician in the Waterford area. And she actually started by becoming an MD PhD. So she was at Brown University, where she has her MD and also a PhD in pathobiology. She then did her family practice residency at UMass in Worcester. And since then, she has been actively providing primary care for a large group of patients, and more recently has had a very nice active voice in leadership within our primary care group at Northeast Medical Group with her experience in running a practice in addition to her medical expertise. And I will kick it off to Ann to introduce her Smilow colleagues.
Great, thanks, Karen. So excited. This is the last one of the year. Really would love for you guys to give us some feedback on other topics. A lot of the topics this year were things that you submitted. So please give us some feedback. Number one, if you like it, that's always good, because then it gives us more impetus to when we talk to folks about doing it again. And then if you give us the topics that you're interested in, then we can really focus on those. It's my pleasure to introduce Dr. Harry Deshpande, my friend and colleague. He's associate professor of medicine, and he cares for patients with sarcomas along with the multi-D sarcoma team at Smilow. He was previously in practice at both the New London Cancer Center and Las Vegas Cancer Center. He has clinical interests in sarcoma, cancers of unknown primary and thyroid cancer. He's also a member of the head, neck, and GU cancer teams at Smilow, and is the director of the medical oncology inpatient consult service. He's a 3-time recipient of the David Fisher Annual Teaching Award and the Smilow Cancer Hospital Compassionate Physician Caregiver Award. So really, really glad to have you, Harry. And then Dr. Igor Latich, who is Associate Professor of Radiology and Biomedical Imaging. He is an interventional radiologist, and that's the first time that we've had an interventional radiologist on, and it's the opportunity to learn a lot from him. He is focused on helping patients, particularly those with cancer, have less pain, improve mobility, and a better quality of life. He specializes in the treatment of degenerative and tumor-related musculoskeletal and spine disease, with a particular focus on pain management. And his research interests span the world of interventional orthopedics, biliary interventions, and quality improvement. He's a graduate of the Yale School of Medicine and completed his residency and fellowship through the Yale New Haven Hospital. Welcome, Igor. So I'm going to turn this over now to Dr. Allard. Here you go.
Wonderful. Thank you so much, Anne. And I had the pleasure to do one of these discussions in the past, last year. And this year, I've had the fortune to do one that ended up being the end of the year. When I first looked at the topic, I said, where are we going with this? And I realized that there's a lot of places to go with this. And just as Karen mentioned, I think that lumps and bumps are kind of a bread and butter family practice internal medicine thing. How many patients seriously do come in to show us their bumps, their lumps, their swollen glands? Sometimes it's a pimple, sometimes it's a cyst. Obviously, we're not going to focus on some of those more straightforward things, but I think before I talk about the first case, I thought I'd just mention some thoughts that need to go through our heads through the years of experience that I've been doing this. Like, is it something that changes the color of the skin? Is it something that's firm? Is it something that's soft? Is it something that's movable? Has it been there a few days? Has it been there a few months? Some of our patients will be quite concerned about a lump or a bump. And as Karen and I were speaking about earlier, it can turn out to be something that's supposed to be there, like your xiphoid process. And I think we as physicians have to take our patients' care and seriously look at what's going on. And then I'm so excited that we have both a radiologist and an oncologist on this talk, because I think one of the things we as primary care doctors can get kind of pulled into is how many people need labs? How many people need imaging? How do we approach it? When do we contact our oncology colleagues or radiology colleagues? Because it is multidisciplinary. But when it comes down to it, the majority of cases will turn out to be benign, right? Probably 99% of these. So let's start with a first case, go through it, and then hear some things from the radiologist as well as the oncologist. So to begin with, we're going to talk about case one. It's a 61-year-old woman who has a history of tobacco abuse, COPD, type 2 diabetes, and lumbar disc disease. She presents with a few-month history of a mass on the right side of her neck. She said it's not painful. She hasn't lost any weight. She doesn't have fevers. But in the back of my head, I'm thinking about, gee, she's a smoker. Could this be good? Could this be bad? Could this be an infection? When I examined her, I realized that it was a pretty sizable mass. It was about 3.5 by 2 centimeters. It was firm. It wasn't really movable, and it was right over her right parotid gland. There were no surrounding masses I could appreciate. The skin didn't seem to be changed. And so I thought to myself, what are the possibilities? And usually when I think there's something in the neck, the first thing I think of is lymph nodes, because I think that's a common finding, but I knew this was right over the parotid gland. So I thought, salivary gland. You could have a soft tissue mass. You could have some kind of a cyst or an infectious process, or you could also have a thyroid process. But anyway, then I thought to myself, like I said, being a smoker, I'm obviously having more negative thoughts. I'm thinking about head and neck cancers and things of that nature. But the bottom line is, I knew this patient needed to have some kind of imaging so we could see what was going on. I realized this was not something that was just going to go away on its own, and that instead we needed to test things out. So that's what we'll see on the next slide. So on the next slide, I did do some blood work because whenever I'm thinking about lymph nodes, I'm thinking about, well, if I get, an ICVC and a differential, I can see if there's any signs of infection, any signs of an, oncology process. And in the case of this particular woman, it was a normal CBC, kidney functions normal, thyroid normal. Again, thinking about the thyroid, but not really because my location is so far lateral on the neck. So then I ordered an ultrasound of the neck, paying attention to the mass. And when they actually imaged the mass, they realized it was a 1.9 by 2.8 by 1.8 centimeter mass in the right parotid region with associated vascularity and internal heterogeneity. And as we often see with our radiology colleagues, if you want to see it a little bit better, I recommend an MRI. And I know what they're talking about because we can see things in such greater detail. I'll let Igor say more to that in a minute, but I want to move to the next thing I did, which was get an MRI for the patient. And as primary care physicians, I think it's important for us to realize how many things we can do on our own and realize how busy our oncology colleagues are. So sometimes we have to consult. Sometimes, right, you can send a message to a friend who's a radiologist and say, hey, what do you think? Well, when you nicely get that read that recommends the MRI, you can move to it and you can get the additional imaging that you need. So in this case, the mass of the right parotid gland was what it showed. The findings could reflect a benign lesion like Warthin's tumor or a low-grade malignancy. It could not be excluded. Mildly conspicuous adjacent sub-centimeter lymph node, non-specific. Again, I didn't appreciate the lymph node. So now I want Igor to help us here and give some opinions and thoughts about imaging masses of the neck, this particular mass, how we approach it, how we biopsy it. Thank you so much, Igor.
Well, thank you for having me, obviously. So this is one of these fairly common scenarios that we're presented with, and it really depends on your practice environment, institution, even within Yale, as to who kind of gets the first phone call. In many cases, these patients are referred directly to ENT, in which case we don't directly get involved unless ENT are unable to get a diagnosis. So if it's something that's obviously palpable, what happens, and I don't know with what degree of frequency, because if an ENT does an FNA in the office, we don't really hear about those, but it's certainly done in the office. So an ENT physician may try to do an FNA in the office under palpation, typically without imaging guidance, especially if something is palpable and under the skin. That said, often we will get FNAs that were performed in the office and they just didn't get enough material. And I'll get into a little bit of detail of how do these different sampling tests perform FNA versus core needle biopsies, but that's kind of the first step. Who sees the patient, whether it's ENT or someone with a radiology background who does it image guided. At Yale New Haven, specifically on New York Street, typically a lot of the glandular sampling interventional radiology do. Many other biopsies, FNAs above the angle of the mandible are done by our neuroradiology friends. So it really depends. For instance, we also cover Bridgeport Hospital, and their IR does really all of it. So there's that basic kind of geographical landscape. Now, in terms of FNAs versus core needle biopsies, so for the most part, in our practice, our go-to is a fine needle aspiration. We feel that in an overwhelming number of cases, we can get the diagnosis without having to perform a core needle biopsy. Why wouldn't you perform a core needle biopsy? At least anecdotally, there can be slightly higher risk of causing vascular injury in the neck area. That said, we typically will use ultrasound guidance for most of these. We seldomly, if ever, use CAT scan guidance because unless it's something really deep, ultrasound gives you real-time feedback. It shows you If there is a more nodular versus necrotic component of a lesion, it also tells you where vascularity is, so you can kind of meander your way into a lesion, nodule, gland. Just looking at basic performance stats, FNA and core needle had a fairly decent specificity. Sensitivity is a little less traditionally for fine needle aspirations. I mean, these needles are typically on the order of, if it means anything to people, 25 gauge. You know, it's the same needle you would use to start an IV, basically, so fairly small. That said, in most cases where we suspect that there might be some uncertainty from an FNA, we will do an intraprocedural prep touch. So we will ask to have a pathologist in the room. We will make a slide or two from our first couple of passes with a small needle. If we have positive material, then we just stop. We don't need to do further FNA. Now and then you will do that and you still come up short. You know, you don't have good cellularity. In that case, we may just perform a core needle biopsy. Typically, core needles are, a little larger, something on the order of 20 gauge. If that again means anything, it can cause a little bit more discomfort in the neck, obviously, and it's a sensitive area. We usually will do most of these with sedation, but a lot of patients are very anxious about having someone work in their neck area, and you can hear us talking, you can hear our biopsy tools clicking. Some patients require anesthesia, but the bottom line with most of these is one of the most frequent, misunderstandings we have is patients come to us and someone, I don't know who, tells them they'll be out for the procedure. This is actually the case with most of our procedures, and there's certainly overwhelmingly not out completely. That, as you know, requires anesthesia. So for the most part, we provide moderate sedation, so they're comfortable, not in pain. So that's really one of the key takeaways that I would like the audience to have, to just prep these patients, that if you're going for any kind of a biopsy procedure, you will be comfortable. You should not be in pain or anxious, but you will not be completely out. And this is where it's helpful for you guys to help us. If a patient, you might tell them this information and they'll say, no, I definitely need to be out. Then we really appreciate it when our colleagues give us the heads up and say this patient might need anesthesia. We will get them involved. Regardless, to just get briefly to one area where core needle biopsy is helpful, especially in the head and neck. Well, two. One is really for lymphomas. You really need a decent size core for them to be able to count, especially, let's say we're not dealing with a glandular tissue, but a lymph node. If they're trying to rule in or rule out Hodgkin's, they really need to be able to see a certain number of those cells in on their slides. Otherwise, with an FNA, they may not be able to do that. So really, for those, we opt for larger cores and multiple cores. And in addition, a lot of our patients undergo various types of molecular testing. With a fine needle aspiration, you really cannot do that. So especially if you're concerned for some sort of a hematological malignancy, we prefer to do core needles. So I think we can advance to the next slide here. I don't want to take up too much of our time.
Igor, just before you do, I think there was a question in the chat, which I can read it to you. It said, is there a place for using point of care ultrasound in the outpatient PCP office for evaluation of lumps and bumps? When should we perform them? When should we not?
It actually could be helpful in many cases. We have instances, as was earlier suggested, when someone feels a lump, and you may not be exactly certain on exam, is this a lump? Is this just normal tissue? Sometimes to just put an ultrasound out of, for one's own kind of education, to look at it and see, oh, this doesn't look like it's anything here. It's just normal tissue. Or sometimes you can have normal lymph nodes. Obviously, we wouldn't expect someone who doesn't have necessarily a training in advanced sonography to be able to tell a normal lymph node from an enlarged lymph node. But in many cases, one can have reactive lymph nodes that still have normal sonographic appearance that probably would just warrant follow-up. But I would say Um, I would never shy away from recommending point of care, especially as a learning tool for us as developing another set of skills to be able to triage things at least. So I encourage it. It's helpful, I think, across the spectrum of care. Our ER friends use it frequently. I hope that answers that. So I don't know if Dr. Deshpande, you wanted to take it from here.
Sure. So in this case, the biopsy showed, as you can see on the slide, scant fragments of bilayered oncocytic epithelium with lymphoid stroma, which is the pathologist's way of saying this looks like something called a Warthin tumor. There was a background of benign salivary gland tissue present, and ENT were consulted, surgery was performed, and the right parotid mass was removed. And the final diagnosis was a 3-centimeter Warthin's tumor with no histological evidence of malignancy, and there was scant adjacent normal salivary gland tissue with atrophic changes. And this is obviously a benign tumor, and whenever I'm called as a consult in the hospital for a patient with a new lump, one of the things I tell my fellows is we have to decide whether this is benign or malignant. Now, usually by the time they call oncology, there are certain features that suggest that it's malignant, but sometimes we can be surprised and have a finding like this, which shows benign changes. And I just want to say on something Dr. Latich mentioned on the previous, one of the previous slides about fine needle aspirates or core biopsies. One thing I tell my fellows in the neck is it's never wrong to start with a fine needle aspirate. And certainly if there is a question of lymphoma, then they can always do a core afterwards. But one thing that we don't want to do, and this will be a recurring theme during this session, is you don't want to do a biopsy that may possibly change the surgical operation that the surgeons have to do, because generally they do have to remove the biopsy tract as well. So sometimes the head and neck surgeons will be able to do what they call a modified radical neck dissection. But if a very large biopsy is done for a squamous cell carcinoma, then they may have to change it to a more of a radical neck dissection. So I don't know, Igor, would you agree with that? Or?
Certainly, and this is something we'll touch on in some of the subsequent cases. This is something that has been of concern to our colleagues. In our experience, it has not been as much of an issue in head and neck, maybe because preferentially, I would say overwhelmingly, we do FNAs, especially for salivary gland tumors and most lymph node samplings. But certainly, whenever there is concern, especially if it's a fairly deep pass, we discuss it in a lot of detail with the surgeons and ask for some guidance with respect to the approach so that we minimize any potential seeding. But that typically tends to be more of a concern, especially with some of the sarcomas that we will discuss.
Okay. And then there's another question in the chat that says, is it small enough for an excisional biopsy and totally remove it? Beth, you saw the patient, right?
Right. So, I think an excisional biopsy could have been done, but I feel like I love the advantage of the fine needle assessment leading to the complete procedure performed by the otolaryngologist myself.
If I may add, one of my colleagues, and this is a common, obviously, understanding in the universe that there's really no such thing as free lunch. There's a risk to everything, obviously, right? So if one were, as we know, there are various nerve structures running through the face, through the parotid gland, and if, let's say, one were to do an excisional biopsy for something that proved to be then benign and potentially damaged branches of the facial nerve, it's a little hard to then retrospectively explain the reasoning for having subjected the patient to that. So there are certainly times and places, especially when, again, concern is Hodgkin's, for instance, that our surgical friends will just go and excise the whole nodule. It gives you definite understanding of what you're dealing with. But when it comes to salivary glands, in our experience at least, I think our surgical colleagues make sure to be very careful, because, as we already said, many of these lesions are benign, really. So you have subjected a patient to a little more of a riskier procedure to get to the diagnosis. Any other queries?
So we'll move on to our next case. And case number 2 is an 81-year-old woman with a history of high cholesterol, COPD, obstructive sleep apnea, dementia, renal cell cancer, ulcerative colitis, and she presents with a large soft mass along her right flank. She says to me repeatedly when I see her for other visits, "Oh, I've had that for years." And she kind of has a reference to this thing on the side of her body. She thinks it's a lipoma. She hasn't had it checked out lately, but it occurred over the last year, this is a live case that's occurring now, is that she's had some bouts of pain occurring both in the right side of her abdomen over this mass, and also over her abdomen itself, so both her flank and her abdomen. And, that brings up a concern for me, and that's one of my lump and bump pearls for all of us to remember. It's one thing to have a lump, but when the lump hurts, kind of raises our suspicion. Is it an infectious process? In this case, because we've been told it's a lipoma from prior imaging, is something changing in this lipoma? Is this lipoma growing into this woman's, abdominal organs? I don't know, but I definitely feel like it's something we need to check out. So when I do her physical exam in the office, I see that she has got a large protuberant mass, 14 centimeters long by 10 centimeters wide. It's soft. It's somewhat movable. Her anterior abdominal exam is completely not revealing. She doesn't have any rebound, tenderness, any other masses, any other signs of issues, normal bowel sounds. So now we'll move on to the next slide and look at the analysis that gets done. So recently she's had lab work done. It shows a normal complete blood count, LFTs. Her creatinine is 1.5, which is up a little bit from her baseline. But remember, this patient is also a renal cell cancer survivor, so she only has one kidney. Her calcium recently was 11.6. Obviously, I've got that in boldface for a reason. I'm concerned. And she's had a CT done, and the CT scan reveals a 13 by 11 by 15 centimeter right lateral thoracic wall lipoma, slightly increased in size from the last exam, which I believe had been done 2 years ago. She has a stable 4 centimeter left hepatic mass, previously characterized as a hemangioma. She has a small hiatal hernia. She has a calcified uterine fibroid. So before I turn it over to my experts, my radiologist and my oncologist, I want to let you know that I certainly was a little concerned about the calcium, and we all know that hypercalcemia can be a possible sign of malignancy. So I've got a concern about that. And then the other thing that's going through my head is, even though this is one of those 99.9% of patients with lipomas who come into primary care offices, although they may choose elective excision, they are usually benign. But every once in a while, they're not. And it's very important for us to think that way. And I think the reason this case is good to me is because it is such a large lipoma, and I want someone else to be involved. I want someone else to take a look at this. I want them to look at the imaging. So let's hear from our first from our radiologist, Igor, to see some thoughts he has about it. Thank you.
Thank you. Well, if we can advance to the next slide. Now, before I look at these images are of a different patient, but I wanted to illustrate a few points. One is typically, so if we're looking for evaluating a lipomatous tumor, lipoma specifically tend to be very well circumscribed and homogeneous in their appearance on both CT and MRI. Now, the lesion that you see down below, even though the image on the right-hand side appears fairly homogeneous, it is so for a reason that I'll explain in a second. On the left, you see that that's an enhanced image on an MRI. It's not homogeneous at all, obviously, but typical lipomas, homogeneous, and a simple thing for you guys to do if you just pull up PACS, open a patient's CAT scan. If there is a CAT scan, you can, one of the tools is a little spherical region of interest, ROI, it says on it. You can just put it over the lesion and see what Hounsfield attenuation density it measures. So typically, fat should be somewhere in the negative range, negative 100s to 50s, 60s, right? So you look for that homogeneous low density, and you compare it typically internally to the sub-Q fat, and you say, okay, well, it looks about the same as sub-Q fat. Now, this patient down below, if you look at sub-Q fat, I don't know if you can see my cursor, which is pretty dark there, the contrast enhanced MRI, this is very much not the same density, right? So you can automatically tell this is not simple fat, this is something else. So that's CAT scan. Other things that you look for in additional to this homogeneous low density is, yes, you can have thin septations. It's okay, 1, 2, even 3 millimeters septations thin. Typically, those septations do not enhance. If you have especially thickened septa, nodularity that enhances, like in this patient, then you start to get really worried, because lipomas do not enhance, do not have thick septa, do not have nodularity. Now, MRI, I know sometimes can be, it's similar to interpreting an impressionist painting, you know, trying to imagine things and figure out what's going on. But MRI, similar to CAT scan, you have that internal comparison, which is your sub-Q fat or fat anywhere else. So if you look at all the different sequences, and if the lesion has the same density as the adjacent fat on all the sequences, the same signal that is, then it's probably going to be a lipoma. Now, if you look at this lesion, you see on the left-hand image, you have a fair amount of, this is a contrast enhanced, like I said, fair amount of enhancement. It's all this white stuff with some dark stuff in between. So the dark stuff is probably just fat that kind of hadn't degenerated. And the enhanced stuff is the sarcomatous degeneration. Now, it's the same image through the same area, image on the right. Now, this is what they call a T2 image. Now, this typically shows you stuff that is highlights proteinaceous type material. So this was actually one of these subtypes of liposarcoma that we call myxoid, and Dr. Deshpande can speak more eloquently on these. But typically these myxoid lesions light up like a light bulb like that, and clearly this doesn't look like a lipoma like fat, because everything else around it, this is the brightest thing there. So, again, some basic things: homogeneous, low density, thin septations, no enhancement. If we can jump to the next slide.
Actually, it looks like there was another question which might be relevant here. So it says, is there any soft tissue mass you'd recommend as CT over ultrasound or MRI for the first imaging? And this provider had a situation of a new posterior gluteal mass with high clinical concern. He or she called Yale Radiology to inquire if MRI would be the best choice, but was told to go to CT. The CT showed a high concern for malignancy, and an MRI was then recommended. Was the CT recommended due to location? And if there's a similar situation in the future, should we start with MRI or CT? I just want to say, from someone who orders these scans, if you order an MRI, you could be looking at 4 months down the line. That's CT.
I think that's probably the reason. They assume that it could be used as an easy triage tool to at least make sure it's something how do we say, less aggressive than what it turned out to be. I deal with this myself, even though I'm in radiology. I do a lot of spine interventions. If I were to request a spine MRI, they still tell me you got to wait 6 months, you know. So anyway, that is a topic for a different discussion. I would say if I had to work up something that I had a suspicion is some sort of lipomatous malignancy, I would just go straight for the MRI. CT will not give you the definitive answer. Even the MRI wouldn't, but at least with an MRI, especially, I don't know if it's gluteal region or if it potentially invades on the or encroaches on the lumbosacral plexus, getting an MRI is helpful to also look for that, to see what are the adjacent neural structures that you have to worry about, because a CAT scan can't really identify those as readily. You can see where they are, but I would say that an MRI definitely gives more versatility, such as in this case, because you can play with these sequences, and we do it sometimes in real time as we acquire these images. If there's any suspicion, they may acquire another 1 or 2 sequences to try to suppress this and that to give you a better answer of what's going on. With CAT scan, you know, what you get is contrast, no contrast, and that's about it. So it's helpful for triage, but for these sorts of things, I would probably go with an MRI immediately if you can get it quickly. Okay, so just to briefly discuss just some of our performance specifications of when we do biopsy, right? So when do we do biopsy? And it turns out maybe dissimilar to some extent from biopsying bony lesions. Biopsying some of these lipomatous tumors can be dodgy business. If we can just scroll back to the previous slide for just a second so we can see the point, right? So again, if you look at the image on the left-hand side, that's the contrast enhanced one. When we do biopsies, we'll typically do this with ultrasound or CAT scan guidance, right? And it can be hard to see where that more dense nodularity is. And sometimes you make a pass I usually will make 5 passes with the largest needle we have, just to increase the likelihood that I will get something, or that I will at least minimize false negatives. But you may hit, you know, this dark area that looks like an egg, and you may come up with nothing, or it may downgrade the tumor. You may think that you got the samples that you got back may be a well differentiated type of a lesion as opposed to more de-differentiated. Correct, right there. So there is a decent chance of a sampling error. So now if we can go forward, just so we can briefly look at those. So as you can see here, and I don't know who does fluoroscopy based biopsies of these sorts of things. I've never done one, but I suppose if you have another choice in life, most of us will do CAT scan and ultrasound. As you can see, the accuracy is, I mean, it's greater than 50%, but it's not, 95 plus. So meaning these are patients that definitely had then excisional proven sarcomas, but we did a biopsy, and in 71% of cases, when done with CT, we got the correct answer. So the rest of it was essentially all false negative. So that's why we don't always do or frequently do biopsies for a lot of these lipomatous tumors, because the chance of sampling error is decent, right? It cannot be entirely ruled out. No matter how many biopsy passes we make, there's still possibility that even on 5 passes, I might have missed the target tissue completely, even though I do my best to look for the nodularity, thick septa, if I can target those. Nonetheless, there's a possibility for that we may come up with a false negative. So if you don't mind, let's just advance to the next slide. Now, not only is there concern for having false negatives, there's also or at least traditionally, there's been a lot of concern regarding tract seeding. And, paradoxically, one may think that doing an open excisional type biopsy that that risk would be less, because certainly you get more definitive answers, and we think, and we have better control over the field. But obviously, you open up more of that potential tumor to spillage and to being dragged back. With core needle biopsies, the risk, at least these are retroperitoneal lesions that we have biopsied, the risk is fairly low, but nonetheless, it's there. But there is an evident fact here that patients that did have some tract seeding subsequently have had reduced recurrence-free survival. So this is a realistic concern. So this is something that we always discuss with our orthopedic and oncology colleagues. Is this worth biopsying? Should we just go, assuming that we can adequately stage this, and just excise it all together with good margins and not have to worry about any of that? I think at this point, we'll turn it over to Harry.
So this particular case had a large mass on the lateral chest wall. Was that
Lateral flank, lower abdomen.
Lower abdomen. Okay, and as you mentioned, lipomas are present in about 1 in 100 people, whereas liposarcomas, or sarcomas in general, only affect about less than 20,000 people in the whole country each year, and that involves over 100 different types of sarcomas. So they're obviously much rarer. This is much more likely to be a benign lipoma than a liposarcoma. But we do see some liposarcomas, and just because it seems like it's like job security for me to make sarcomas as complicated as possible so that no one else will want to do them. But there are at least 5 different types of liposarcomas, but the ones that probably are more common are well-differentiated liposarcomas, which are, as shown on this slide, they can be locally aggressive. Sometimes they grow to very large sizes, but typically they don't metastasize. And generally with sarcomas, the surgeons are going to want to remove the mass and also remove a 0.5 or even 1 centimeter margin all the way around. But well-differentiated liposarcomas may be an exception to this, because they can be very, very slow growing. And sometimes the surgeon will say, well, we'll just do a very marginal excision of these masses, because just like Dr. Allard had said, this patient said it had been there for years, and if this was a well-differentiated liposarcoma, it may take another 60 or 70 years to get back to that size. So you don't want to give them a very aggressive, potentially damaging operation if she doesn't need it, or even an operation at all if she didn't, if it wasn't bothering her. And one of the questions on one of the previous slides was, can lipomas be aggressive, or can they be malignant or something? So if the malignant lipomas are what we call liposarcomas, but lipomas themselves can grow to large sizes and generally can grow over time if you're following them. But again, it doesn't necessarily mean they have to be removed. I think they can be safely followed as long as they don't have aggressive features that Dr. Latich had mentioned on imaging. Some of the other subtypes, though, so we mentioned the myxoid type and the dedifferentiated type, they can grow very, very rapidly. And we've seen cases where someone is extremely healthy, doesn't feel anything, one person in particular went on vacation and came back with a huge mass the size of a basketball in his abdomen within a few weeks. And obviously those are thankfully very, very rare, but those are certainly, if you see something that's growing very rapidly and more importantly that's causing symptoms, then those are the ones you don't want to say come back in 6 months. You want to get them in sooner rather than later. I know we're running a little low on time, so
Mhm.
this is,
So we'll-
I think, back to you.
Yeah, we'll move on to our last case, and I will give full credit to Dr. Deshpande for providing this case, but I think that I'm just going to talk briefly as a primary care doctor. We have a 29-year-old man for case 3, and in 2020, he presented with pain in his proximal right tibia. Stop for a minute. We deal with pain all the time as primary care doctors. People come and go, their ankles hurt, their knees hurt, their hips hurt. But notice I'm not really talking about a mid-bone pain, unless someone comes in, like I just had a patient last week, she has a hematoma from a traumatic injury. But I think what stopped me right away about this particular case is that it is in the middle. And so when we need to determine who needs imaging and who doesn't, I think we need to ask ourselves, is the pain the patient is experiencing related to a traumatic injury? Is it related to a change in activity? Can I explain it through an overuse injury or trauma, or can I really not explain it that way? In which case, I need to move forward with additional thoughts about workup, and in this case, turn to imaging. So I think Igor is now going to address the changes that were noted for this gentleman when an x-ray was performed and additional imaging, and we'll hear more about the findings of this particular found to be bony lump.
So yeah, so whenever you look at obviously typical workup of these lesions usually starts with radiographs, and they're extremely helpful, not just as a triage tool, but our pathology friends will inevitably and invariably also, once they've reviewed their slides from an eventual biopsy, look at the images and say, plain films, not so much the MRI, but x-rays, and try to reconcile whatever they call it with the radiographic appearance. It is very helpful to know some of these basic patterns, at least if you're trying to be helpful to our clinical colleagues, and we all hope that and plan for that. But if you look at these radiographs, for instance, you can see that in the proximal tibia, you have first of all, all these other changes, sclerosis and lytic changes, that's abnormal. But one thing that normally benign lesions don't do is you don't break through the cortex like you broke through here on the medial side. I don't know if you can see my cursor, but you see that the cortex is interrupted there. Normally, benign lesions won't do that. Maybe osteomyelitis would, but typically you don't really get it in that location. Right? So typically that would be automatically considered an aggressive feature of this lesion. And then once you jump to the MRI, you confirm that medial cortex, if you follow this black line, that is the periosteum. On the lateral side, it's fairly contiguous. On the medial side, it's interrupted as you go up towards the medial meniscus. So that automatically tells you it's an aggressive process. I mean, we don't know what it is yet, but this is not some sort of a benign lesion. And in MSK radiology, it's really all about triaging it to in these two general baskets, benign appearing or aggressive appearing. So once it's deemed to be aggressive appearing based on that cortical breakthrough, based on significant perilesional edema, again, I don't know if you can appreciate. So you have these larger, more confluent areas of bright signal, which is the tumor itself. And then adjacent to it, extending into the lateral condyle, you have this area of kind of more diffuse, subdued brightness, which is the perilesional edema. Yes, you can see that with some benign lesions too, but usually it's not as disorganized and chaotic as this is, and particularly you don't have cortical breakthrough. So all of these things tell you that we're dealing with an aggressive lesion, and that's, again, all we need to know at this point before we do the biopsy. And then I'll just continue really quickly. So, in terms of biopsying these lesions, so here, core needle biopsy actually performs maybe a little better than with some of our lipomatous tumors. In other words, the likelihood for false negatives is a little less. This tissue is a little more densely packed. You're not dealing with a 15-centimeter lesion and, you're biopsying 3 millimeters of it somewhere. Typically, there's much more activity in a small area. So A core needle versus open biopsies basically have the same, roughly same performance here. And again, this is something where we discuss very precisely with our surgical colleagues what their operative approach would be to excising and repairing one of these so that we stay in that plane with our biopsy tract. And this is not very hard to kind of ascertain. You just imagine a clock face and okay, go at 2 o'clock. And typically these, because we're also biopsying bones, so it's more dense material, we can use much larger needles. Typically, again, if we were thinking about the neck, 20 gauges are kind of go-to. Here, you may use 10, 13 gauges, a much larger needle, so you're getting much more tissue. And for the most part, there's really not going to be a huge difference in your diagnostic accuracy between percutaneous sampling and open for most subtypes of bony sarcomas, but chondrosarcomas can be a little tricky, and Dr. Deshpande can speak more eloquently on this, but you can sample more normal appearing cartilaginous kind of matrix, and you may not get necessarily the perfect answer that you need to get. So doing a biopsy of a chondroid lesion can sometimes be tricky, and perhaps doing an excisional or a complete surgical excision would be probably the preferred approach for some of the chondroid lesions.
Yes, so as Dr. Latich was saying, there can be different histologies in the bone. We tend to think of bone lesions in oncology as, again, they could be benign or malignant, so you do get some very unusual benign lesions that we look at tumor board every week that the surgeons will say, we'll just follow these. But then we also get malignant lesions, and the most common malignant lesion in the bone is actually a secondary lesion. So we always think, is this primary or secondary? And metastatic lesions in the bone are much more common than primary bone tumors. But usually in those cases, you know the diagnosis going into the biopsy. The most common bone tumor in people is osteosarcoma, but the most common in adults is actually chondrosarcoma. And as Dr. Latich says, there's different types of chondrosarcomas. Some of them can be well differentiated and really not grow very much for years, sometimes decades, whereas other ones are more what we call dedifferentiated, or other types that are a little more aggressive and need to be treated more with aggressive surgery and sometimes chemotherapy as well. Osteosarcoma, along with Ewing sarcoma, is really one of the huge successes of chemotherapy. So up until the 1940s, these were fatal diseases even when they were fully excised. But then when chemotherapy came around, the survival rate for osteosarcoma went from 20% 5-year survival to 80% 5-year survival with a very intense chemotherapy. These are mainly seen in children, but there is a second peak in adults, which is thought to be sometimes related to Paget's disease. And as you can imagine, children tend to be able to tolerate things a lot better than adults, and there are certain chemotherapies, mainly high-dose methotrexate, which we can't give to adults generally over the age of 40. So the survival rates in adults is not as good as in children. But still, it's a very chemo-responsive disease. And similarly with Ewing sarcoma, so on the X-ray that we showed earlier, the osteosarcomas tend to affect the ends of the bone and cause these characteristic findings. So you can get a sunburst appearance or a Codman's triangle where the periosteum is actually lifted off the bone. And sometimes that's very easily seen just even on an X-ray. Whereas Ewing sarcoma affects the middle of the bone, the shaft of the bone, and causes an onion skin appearance, which you may remember from medical school X-rays that we all had to look at. But then you can also get other strange tumors. I've listed a couple of them here, but these are very, very rare. So I think you're more likely to see either non-malignant conditions, or if you are going to see malignant conditions, it's probably going to be a metastatic lesion to the bone, or osteosarcoma, or chondrosarcoma.
Okay,
So
so
that brings
we
us
should-
to the end of the formal part of our presentation. We actually answered questions as we went along. I'll just give Beth and the other panelists to see, are there any questions that you have for each other before we wrap up?
No, maybe I shouldn't have answered the question. I forgot. I just saw them pop
No, it
up.
worked
So
very well. It actually worked well. No, and the timing was actually perfect. Your preparation and presentation was really outstanding. Thank you so much for this. I feel like I was just gathering primary care pearls and pearls of what to do when people present with similar things. Thank you everybody for joining. There is a survey at the end if you can hang on for a few minutes, and CME is available. If you don't get it, you can reach out. And similarly, if you have any interest in being part of our presenter panel for next year, please reach out directly to me, karen.brown@ynhh.org, and we would love to have you.
Have a
good
great
rest of
summer.
your evening. Yes, have a good summer. Thank you all.
Thank you for having us.
Thank you,
thank
everyone.
you for having us.
Have a good night.
Happy summer. Good night.